Welcome back to Your Health radio and television program. I am Dr. David Morwood. I am a board-certified plastic surgeon. Thanks so much for joining us. And I am once again delighted to have on my program Natalie Harris, registered nurse. Natalie, thanks so much for being with us.
I'm glad to be here.
Now, Natalie, let's back up a second. I want to, again, talk about this concept of registered nurse. Now, I know there's different levels of nursing, right? There's like the LVN, and there's a nurse's aide, and there's the RN BSN, et cetera. So can you give us a little background about really what that means? What's it mean to be a registered nurse?
It's the level of licensure.
So you're licensed?
Yes.
So a nurse has to have a license?
We have to have a license. We have to pass the Board of Nursing exam to maintain that license. You have to be licensed in the particular state in which you're working.
I hear it's not easy to get a license. I mean, it's not easy to pass that exam, is it?
It's a very difficult exam. It's all computer-based now. But yeah, you have to have a very strong foundation.
And Natalie, where did you get your training to become a registered nur's?
I went to Columbia School of Nursing in New York City. And
New York City,
yeah,
wow.
Yeah.
That's busy.
Yeah, it was a very busy program. I did it in 12 months straight. I already had a bachelor's degree, so I did what's called an entry to practice program, where you do the entire nursing major in 1 year. And
wow.
then I'm ready for the exam. So.
And did you get separate training to become an emergency room nurse, or?
You do need, as a new grad, I did enter an orientation program at UCSF. It was 8 weeks of intense training, and then you're on your own.
Wow. So what's the training like? Is somebody sort of hugging you and you're with a buddy nurse constantly? Or?
They provided 2 days a week of classroom orientation. We actually learned disease processes, what to expect. We were taught by other nurses, and doctors came in and gave different lectures. And then we did 2 12-hour shifts a week with a preceptor for 8 weeks.
Well, that's a lot of work.
In conjunction with the class to prepare, and then we were on our own flying solo. So it's definitely a quick entry.
Well, Natalie, you know, as a plastic surgeon, and for my surgical training, I was an intern and resident, and my fellowships were in all big cities, or I should say all of them were in big cities, New York and Paris and London and Los Angeles. And I found it's a great place to train because it's so busy.
Right.
Don't you think? You're hardly ever sitting around.
It's very
There's
busy.
Always cases
Exactly.
to do, right?
You're going to see
operations.
a wide range of patient population. You're going to tend to see more critical patients with comorbidities. They're going to be much more complicated than, say, just a more country ER, if you will.
Right.
So.
Well, Natalie, you know, common questions that come up when people go to the emergency room, you know, they always want to know why they have to wait.
Right. Why is this taking so long? Yeah.
Why is this taking so long? And they come in and they know or feel it's an urgency or an emergency, and they want to know why it's taking so long. So how can we help people to understand why there's going to be some inevitable waiting?
Well, first of all, as most of us know, our ER today they're very crowded. We're losing ERs, they're closing ERs for financial reasons, but basically we have such a high census coming through that's part of the problem. And then secondly, you're going to be triaged by a triage nurse who is specially trained to be able to see what level of acuity you are at. And if someone comes in with a higher acuity, they're obviously going to be seen first. Unfortunately, our ERs are becoming more like primary care clinics. Some people who think that they're a little bit more, sicker than maybe they actually are based on their vital signs. The nurse will do an assessment and make that determination. But everyone who comes thinks that they're a top priority. And everyone's a priority, but we have to do it based on actual medical need.
Well, we have to prioritize, right? The people who have really emergency, urgent events going on, need immediate attention, and the other people, unfortunately, may have a delay or experience
and
a
often
delay.
Children or elderly are going to probably get prompter service because they're going to have more acute problems.
Right.
So.
Well, Natalie, in my experience in training, I worked in some emergency rooms where there was a medical part of the emergency room. There was a surgical part of the emergency room. There was a part where there's especially for pediatrics. So what's your favorite part of the emergency room? I mean, do you like the kind of injuries where you have to stop bleeding, or triage car accidents, or do you like the chest pain, kind of more of the medical side? What do you like?
I definitely like more of the medical side.
That's a lot of investigative work, isn't it?
Because it requires more skills, it requires more procedures, and I like variety. That's why I chose ER, because I wanted to be able to do lots of different things throughout my day. I've never actually worked at a level 1 trauma center, so I haven't seen, we would get minor car accidents, but I actually haven't had a lot of experience with gunshots or that kind of thing.
Well,
so.
it's a lot of action, and it's a lot of stress, but we help a lot of people. So, Natalie, let's talk about the advice that we can give to people who come to the emergency room. What should they bring to the emergency room? What should they not bring? Should they bring family members? Should they bring their medications, et cetera? So what advice can we give to people who come to the emergency room?
Well, that's a good question. Yeah, to expedite everything, bring as thorough a medical history as you can, and include especially medications. If you have a list, we need to know the medication, we need to know the dosage, we need to know how often you take it. Sometimes we need to know why you take it, because there are certain reasons, for different medications.
Now, Natalie, I think that's so important what you're talking about, but let's explain to our audience why that's so important that people bring in their list of medications.
Well, it's important because we need to have an accurate history of what they're taking, because we need to know what might be interacting. Different medications can, if you take them at the same time, can cause a different medication to act differently. We need to know if we're going to give you new medications, if they're going to interact with that particular medication. Perhaps the medication you're taking is causing part of your problem. So we need to know that. We also need to know who's prescribing the medications. So if we have questions for the prescriber or your primary care doctor,
so
we have
Natalie,
that information.
well, I think that's very helpful.
Because we spend a lot of time doing that kind of research. And again, that slows down the entire process.
Right.
So.
Now, what about family members? Is it okay if a patient brings a family member or a bunch of family members?
Yeah, we typically try and keep it to 1 to 2 people just because of the small space, the nature of the ER. You just have a little cubicle of your own. But yeah, some support is great. It's not great to bring small children. We never advise bringing children to the ER because it's dirty, there are diseases, that kind of thing. We don't want them to get sick, and that just creates more chaos. So usually children at home, but family members are important, especially if there's language barriers, which is becoming more of an issue. It's hard, if there's any language, if you can have a family member who speaks English and that language as a translator, that's always helpful because.
Right. Natalie, one of the most common questions that I hear, and I heard throughout training, someone will want to know that they arrived to the emergency room before someone else, but then that other person who arrived after them gets in the door first or quicker. Is there a way to explain that to people, why that sometimes happens?
Yeah, it's going back to that whole system of triage, finding out who is the higher acuity, and there's nothing personal. It's all based on who has the most pressing medical need.
Right.
And that's how we're going to have to treat people.
And understandably, that's difficult for people to understand and deal with, because anybody who comes to emergency room, they're stressed, they may be in pain, they're worried and anxious, and they want to be taken care of.
And other patients, they can't see what's going on with that person, so they may look perfectly healthy being taken back, but they don't know what's going on inside, that we do because we've seen the vital signs, or maybe we do know their history, maybe they've already been a patient before. There's a lot of factors. So.
Right. Natalie, let me change the subject a little bit. Throughout the hospital and even in the office, of course, I'm in private practice, and so doctors and nurses work very closely together. And I think one of the areas where doctors and nurses have to work well together is the emergency room. And I know that the number of nurses staffing the emergency room may be at times 5 or 6 times the number of doctors that are on duty. And you all have to work very well together. And as a nurse, you may have more than one patient going on at one time, isn't that right?
Yeah.
Now, you may be supervising and caring for a few different patients.
4 to 5, typically.
So, see, now that's something I didn't know. So at one time, you can have 4 to 5 different patients under your care.
Yeah. You're pretty much always going to have that in any ER in this state. So, yeah, because we're busy. But.
And so how do you work well with the doctors? I mean, how do you work that out so it's efficient and patients get taken care of? And another common question is, patients want to know that if the doctor orders a medicine, that it's meant for them and not the person in the room next door. So what do you do to make sure everything goes the way you want it to go?
Well, like I said, it's a lot of teamwork, a lot of communication. I would say the nurse is sort of almost the primary person, because you can have one doctor in the ER taking care of 20 patients. So it's the nurse's job really to stay on top of, again, communicating lab results to the doctor, communicating when the test results are in, if the CT has been read, bringing that doctor back to the patient. They're communicating the patient's needs, if pain medication is needed, that kind of thing. So really the nurse is the primary contact with the patient. Oftentimes the nurse sees them first and will do their assessment, go to the doctor, let the doctor know if we need them immediately or not. There's also protocols set up in ERs a lot of times these days, set by a doctor that say if a person comes in with these set of complaints, a nurse can initiate a series of tests on their own to get the ball rolling.
Well, that's interesting.
Something like a chest pain, if you suspect a heart attack, there's a certain protocol you're going to follow just right off the bat.
Well, that's fascinating to me. So certain symptoms or a certain set of complaints, when a patient comes in with those symptoms or set of complaints, then the nurse can initiate the workup, right? So, Natalie, that's another term that comes up again and again and again, this idea of a workup. Can we explain to our audience what we mean by a workup?
A workup is basically a battery of tests.
It's an investigation.
An investigation based on the primary complaint. And oftentimes patients will come in with multiple complaints, and we kind of have to get them to tell us what is your main concern, what is causing the most pain, to sort of target what we're going to be investigating. But yeah, the most common complaint in the ER is abdominal pain. And so that has, like I said, a workup that goes with it. The next would be chest pain, which has another workup that goes with it. And primarily the big two.
It sounds like the emergency room nurse has a lot of responsibility.
She does.
Because you can actually start a workup. In other words, start the investigation. You can get the ball rolling with a chest x-ray or abdominal films.
Yeah, and basic labs, urine tests. So we really cover a large gamut with these protocols. And that does speed things along. The doctor will come in, on occasion, he might change something or add something. Most likely it's add something. So, and we already have the blood drawn, so it's really easy to do that. So.
Now, Natalie, well, what about calling in consultants? That's another area where people, of course, they get impatient and they feel like they waited in the waiting room, and then they get in and then they see the nurse and they finally see the emergency room doctor, and then they wonder why they have to wait for, say, a medical consultant or a surgical consultant. Now, how do you explain that to the family and to the patient?
Well, just like if you were to see your primary care doctor, you do need to be evaluated first before they can decide if that specialist is needed. But if an emergency room doctor has a general, wide knowledge of many things, but they aren't specialized, so they want consultation to make sure that they're making the right choices. And
of course, we don't staff an emergency room with a cardiologist
No.
or a plastic surgeon or an abdominal surgeon, right?
If you're in a big hospital in a big city, they might be upstairs on their respective floors. They can come down within hopefully an hour or two. But sometimes I worked in a smaller hospital in Oregon where they were off-site, so they would have to come in, especially late at night, or maybe do a phone consultation with the ER doc at least. But it did take time. But
so Natalie, you have a very interesting background. So you've worked in Oregon, and you've worked, obviously you're working in California, you've trained in San Francisco, and you trained in New York City. So for yourself, do you like the kind of busyness and stress, really, that comes with a big city emergency room, or do you prefer kind of the laid-back, more, I guess, relaxed atmosphere in a smaller emergency room?
I enjoyed my training. I enjoyed my experiences. I mean, that's why I got into nursing, is I wanted to be on my feet. I wanted to be busy, working with people, using my skills. I learned a lot. So I really did enjoy the experiences I had. I went and did agency nursing, where I would be assigned to a particular hospital on a given day for a shift, fill sick calls or vacation, that kind of thing. So I really got to see a lot of places in San Francisco and Portland, Oregon. But you burn out. You burn out quickly. So
it's a lot of work, isn't it?
It is. It's a lot of stress. It's a busy day for 12 hours straight. And now, if I were to return to the emergency room, I would want to work in a smaller, place. But
one of the aspects that I quickly became aware of when I was covering emergency rooms, especially as a surgical resident, was that the patient is there, of course, who needs attention, but oftentimes family members are also anxious and they're worried and they want information about what's happening to someone they care about. And I found that thankfully I could lean on the nurses to spend more time with the family and give explanations. Now, Natalie, do you enjoy that part of the work, talking to family members?
I do. That's one big reason I got into nursing was I like talking to people. I do like the education side of nursing, and there's a lot of that going on in the ER, explaining the whole process, explaining possibly what their diagnosis is. We spend a lot more time with the family, and although I have heard research is that's #1 complaint in ERs is lack of information, like lack of being kept up on what's going on with the family, and that's frustrating. We get busy, but it's definitely a goal of every nurse to keep the family abreast, to keep everyone calm and feeling comfortable, and try and make it as least scary experience as possible.
Well,
it's very intimidating being in the ER as a patient. It's loud, there's stuff going all around you, and
it gets scary for people.
Oh yeah.
And it gets stressful.
Yeah, right.
So Natalie, what about the people working in the emergency room? Like, did you ever find yourself that you just needed to take a break, or you just needed to take a deep breath, and you asked a colleague to cover for you, and is that okay to do?
Usually in those moments, there's no one to cover for you, which is the problem. But you get through it, and then afterwards, you go outside and take some deep breaths. And I won't say I didn't have some rough shifts where I shed some tears at the end, from stress. But
it's a lot of work.
It's a lot of work, but it's
being an emergency room nurse.
You learn so much. I would recommend any nurse that thinks they can handle it to do it, because it's a great experience. It will be the hardest, probably, rotation that you ever do, and you'll learn so much about people, about medicine, about.
Well, Natalie, what I've found in my own training, and I think it's true for the nurse, that when you go through periods of working in places like emergency rooms or intensive care units or med-surg floors in the hospital, the knowledge and experience you gain, you can carry with you throughout your entire career. So if you decide to work in another different environment, you can always kind of rely and lean back on that knowledge that you gained when you were in the emergency room or the ICU. Don't you think that's true?
I absolutely agree with that. Yeah, it has served me very well. Most nurses don't jump right into that right out of school, but I think that it gave me a great foundation going forward. So.
Excellent. Natalie, we have just a few seconds left. You're not working in the emergency room now, but tell us about your current position.
I currently work in the post-anesthesia care unit at the Monterey Peninsula Surgery Center. So I do outpatient surgery, and I prep the patients and recover them after surgery. Again, doing the education and getting them ready to go home and recover.
Well, Natalie, as you know, I have a bias. I think the Monterey Peninsula Surgery Center is terrific, and that's where I do my outpatient surgery, or much of it. And I so much appreciate your help, and I admire what you do there for everyone, including the patients. And I'm so glad you came on the program. I hope you come
Thanks
again.
for having me.
My pleasure. Natalie Harris, registered nurse. You've done all kinds of things, ER nursing, and worked up north, and now we're at the Surgery Center. Thanks so much for being here.
Thank you.
I am Dr. David Morwood. I'm a plastic surgeon, board certified, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause.